Thanks for tuning in to the Women's Vibrancy Code, a podcast dedicated to helping women move from exhausted to energized, balance their hormones, and feeling turned on by their life, their lover, and themselves. I'm your host, Maraya Brown. I'm a Yale and functional medicine trained women's health expert, midwife, mom, keynote speaker, and self-made entrepreneur. I'm the founder of my signature program, the Women's Vibrancy Code. So sit back, relax, and let's chat about your energy, hormones, libido, and embracing your feminine power. Oh, and you might want to have pen and paper to take some notes on some of these episodes. I have Dr. Daved Rosensweet with me, who is quite the expert on this topic, specifically around bioidenticals. So we're going to be digging into when, why, how, why not, in what scenarios are bioidenticals helpful. I'm sure that all have some personal questions for Dr. Rosensweet, and I'm really looking forward to it. So welcome.
Thank you.
Yeah,
nice to meet you.
Yeah, nice to meet you as well. So Dr. Rosensweet is the founder of the Institute of Bioidentical Medicine and the Menopause Method. He is the author of 3 books on the subject, including the latest, which is called Happy, Healthy Hormones. He graduated from the University of Michigan Medical School in 1968. Early in his career, Dr. Rosensweet trained the first nurse practitioners in the United States and was in charge of health promotion for the state of New Mexico. That's so cool. Dr. Rosensweet, I don't know if you know, but I'm a certified nurse midwife. So I did the nurse practitioner. Yeah, I did the nurse practitioner program at Yale. But I finished in 2007. So there's a little bit of a time gap.
A little gap there.
He is a nationally known lecturer and presenter at the American Academy of Anti-Aging Medicine, the American College of Advancement in Medicine, and the Age Management Medicine Group, as well as more. In 2019, he was called to Washington to speak in front of the National Academies of Science, Engineering, and Medicine on the, quote, safety and efficacy of bioidentical hormones, which I'm sure that you have a lot to say around everything that happened. When was that? Like 2002 timing, when everyone said no hormones, and we've come a long way from then. So through the Menopause Method and the Institute of Bioidentical Medicine, Dr. Rosensweet is training medical professionals to master BHRT, bioidentical hormone replacement therapy, using the most advanced and modern tools. His protocol has been used to treat more than 12,000 women. And you'll see in the show notes, or if you're watching on Facebook, in the description, I have his Facebook handle, his Instagram, and his website. So welcome. It's nice to have you.
Thank you. Nice to meet you again.
Yeah.
And also they can download a free copy of a PDF copy of our book, Happy, Healthy Hormones, from your various different sites.
Great. Good. And so if someone were to download that book, who is it for? What questions are answered by downloading the free PDF?
It's a book design I wrote for women who are in perimenopause and menopause, want to get an idea what's going on, and my strong opinions on what the best way to work with it is at any age beyond midlife.
Okay. And if there's someone listening and says, perimenopause, I don't know what that is. I don't know if I'm in it. How do I know? How would you answer that question?
Well, just a little background. A woman's hormone levels, outputting from the ovary, absolutely peak at the age of 20, plus or minus 2 years. Then they gradually decline. So perimenopause really begins pretty early on. They decline at different rates. Some women a little faster, some women a little slower, but they always decline. And then around midlife, they drop precipitously as the ovaries stop producing ovarian hormones. There are consequences of the decline of all 4 ovarian hormones. Yet many women don't really feel it, but some do, even in their early 30s or mid 30s. By 40s, they can creep up on you so subtly that you may not notice a little bit of brain fog, a little bit of dryness in the vagina, switching to lube if you're having intercourse. Um, a little less energy, a little less libido, all kinds of possibilities there, a little less muscle strength, a little less motivation. There are subtle symptoms in some women. They're not subtle at all, especially the further along you get. For 85% of American women, those symptoms can be really the game stoppers. That's a benefit because the intensity of the symptoms inspires many women to ask the question, what's going on here?
Right. Yeah.
And to come up with the right answer. That's what's being called for. And it sets many women off on a process to replenish those hormones for the rest of their life.
Mm-hmm.
And the same thing happens in men. Similar decline, subtle at first, not so subtle after a while. And the intensity of the losses for men inspire many men to go, what can I do about this? Gee whiz. And they do, they get hormone replenishing too.
Okay. You mentioned four hormones. So, for those who are savvy, they're likely familiar with estrogen and progesterone. Maybe they've heard of testosterone, but you mentioned four. So, I'm curious if you would share.
DHEA, a significant amount
Uh-huh.
of DHEA, which is probably more a pro-hormone in that it's converted to other hormones, but
Yep.
it's also put out both by the adrenal and the ovary.
Mm-hmm. Mm-hmm. And so, for those of you listening, we're talking about estrogen. Now, for clinicians, if you're listening, well, estrogen, we've got estradiol, estrone, and estriol, but we're talking estrogen, we're talking progesterone, we're talking testosterone and DHEA, which, like Dr. Rosensweet said, comes from both the ovaries and the adrenals. And it's a hormone precursor that I think of around vitality and energy and immune health. And you happen to mention men and the decline. So, for the men that are listening, do they also have all four hormones? And what are some of the signs of a male equivalent of perimenopause and symptoms that they might be experiencing?
Well, the principal hormone in men of note is testosterone. Men also have estrogens. Men also have a small amount of progesterone and also have DHEA. But the testosterone is so prevalent in young men and it's so powerful that as it declines, well, whether men are paying attention to that decline or not, the attention usually arises when the erection falls and their ability.
One rises, the other one falls. For those listening in the podcast, I've got a hand up and I've got a hand down. Yes.
And, you know, a lot of folks have been familiar with menopause for a long time.
Mm-hmm.
Whereas there was very little known about the decline in men, and it was sort of a secret kept behind closed doors until this medication came out called Viagra or Cialis.
Mm-hmm.
And it got so popular so fast that it revealed that there was stuff going on with men's erection.
Yeah.
And
Yeah.
Viagra it's a wonderful medication. Interesting for me to say that, but it is.
Mm-hmm.
But the core issue is the decline in testosterone. Viagra does something, but it doesn't do the testosterone thing.
Yeah.
And testosterone is so critical for muscles and so many other functions, mood. In fact, for men and women, one of the principal reasons that there is such a thing called assisted living facilities and nursing homes is because of the loss of testosterone
Hmm.
in both men and women.
Wow,
When,
that's a big statement.
yeah,
Yeah.
I know medical doctors that have been at the helm of nursing homes, and they're making a guess somewhere around 80-90% of all people who are living in nursing homes are there because of loss of testosterone. This is men and women.
Wow. Hmm.
Like in 1968, I was a senior medical student, And I was listening to a lecture by a gerontologist who was absolutely shocking. He said, "You're senior medical students. You know thousands of diagnoses. Let me tell you what's really happening to older people. They're losing their muscles through a process called sarcopenia. They can't stand or walk with stability. They fall on their osteoporotic hips. They get a fracture, and in those days, most of those folks died. Want to do something for old people?" he said. "Take care of their muscles and their bones." And the principal thing around muscles, there's two things. Of course, exercise is important, but nobody gets to keep their muscles, or hardly anybody does, without the testosterone. This is men and women.
Yep.
Women have twice as much testosterone as they have the most potent estrogen, estradiol. So it is not a male hormone. It's a human hormone in our muscles, our pelvis, our bladders.
Yes. Oh my gosh, I have so many questions that I'm like jotting them all down. Okay, so with what you just said around the amount of testosterone compared to estradiol, I think of the menstrual cycle with women. Let's talk about a 28-day cycle, an infradian rhythm. My understanding is that the majority of the testosterone is going to be produced during that ovulatory time. So let's say you're on a 28-day cycle. That's generally, say, day 11 to 16, 12 to 16. And then maybe there's another spike of testosterone right before she bleeds. Whereas for male-bodied individuals, it's more like a surge every 12 hours or so. Are you on the same page with this rhythmic pulse of testosterone, that it's not necessarily women are producing those high levels of testosterone all month long naturally before we go to bioidenticals? I'm curious what your thoughts there.
Well, women cycle in a very significant way. The amount of estrogens produced every month starts out real low at the beginning of the month, peaks around day 12, falls significantly around right after that peak, and then it gradually rises to part of the way of recovery, and then it falls and you get a period. That's a dramatic different output throughout the month.
Yep.
Progesterone is similar, different pattern, starts out really low, and if a woman ovulates, and only if she ovulates, she produces this astronomical 100 times more progesterone than she does estrogen. That's why I go off the charts here. And then it comes down, and then it falls, and she has her period.
Yep.
Major cycling going on. In a woman, the testosterone is just not cycling that dramatically. It might have its ups and downs, but it's not a critical piece. And a man, yeah, the testosterone throughout the month, pretty steady.
Yep.
But it does pulse, as you were saying, like there's an output in the morning. Makes sense. It's so energizing. And this is one of the telltale signs for men. Many young men realize that they wake up in the morning with an erection. They awaken with an erection. And that's one of the first things to go. That's testosterone dependent. That's that pulse you're talking about.
Yep.
But as men's testosterone production goes down, that's the number. That's usually the first thing that disappears. Not a lot of men notice that, but when you ask them, you still get those morning erections? No. Wow.
And so then when you are supplementing with bioidentical hormone replacement therapy that might include testosterone for a woman, in an ideal world, are you wanting that testosterone level to kind of mirror a natural rhythm, meaning little bits each day, but more right around mid-cycle and maybe a little bit more right before she would theoretically bleed, assuming she's still menstruating?
Well, excellent questions. One thing is 100% of women have super low testosterone. It used to be that we could say that at least by 3 years with no period, you got super low testosterone. That's highly consequential. We used to know that some women in the perimenopause, they would get a little increase in testosterone and then a fall. So by 3 years, they don't have enough for sure. But the number of women that get that little boost seem to me to be diminishing, because a way that a woman can compensate for her dropping estrogen is produce more testosterone out of her adrenals and
Mm-hmm.
out of the ovaries. But it's brief, it does not last. So what I'm finding these days, unlike 30 years ago, almost every woman that enters the perimenopause has also got low testosterone. Not every,
Mm-hmm.
but most of them do. And it's not hard to learn about that in the medical history. You know, if the libido is down, getting triceps flab there, if you can't do a squat like you used to,
I won't
you've got
admit
low.
it. You've got low testosterone, yes.
Yeah.
And I like what I just heard you say, because it was one of the questions I had jotted down. Is what I've been taught is, as the ovaries start slowing down, it's often the adrenals that get the knock on the door. And assuming, if we're talking about a woman, probably a man too, assuming they have not been existing in high stress, adrenal fatigue causing lifestyle, then as the ovaries, or theoretically the testes, start slowing down and the hormone production is not coming from those places as much, I'm curious if you're in agreement that in a healthy scenario, the adrenals do kind of respond to that knock on the door and take over some of the production. It still goes down, but it's there. Then, on the other hand, with an individual who has lived a high stress life, eaten a poor diet, has not set boundaries, and the adrenals are exhausted, now we not only have the ovaries slowing down, but also the adrenals not responding. And so maybe that's why some have so much more extreme symptoms of the hormone reduction. I'm curious if you're in agreement there.
In many ways, I am. Um, it all relates to what's a dysfunctional response to the stress of life. The stress
Mm-hmm.
of life is a good thing, it's a natural human thing, but how we react to it or respond to it really matters. And we are deeply DNA programmed to respond well. Like if we're walking across the tundra and we get attacked by a saber-toothed tiger, we got to run.
Yeah.
And
Yeah.
all of a sudden, there has to be this burst of internal biochemistry to help us flee or fight. And the adrenals are at the vanguard of the powerful hormones. That hormones are so powerful. And the adrenal hormones are at the front line of that fight or flight response, whether it's cash flow in 2023 or
Mm-hmm.
whatever, or
Mm-hmm.
dinosaurs in a
Right.
long time ago. I'm
Right.
sure we all remember those times. They're a little bit frightening, but the biology is the same. Even if you're worrying and there is no saber-tooth tiger, the biology is the same. You put out, well, the two major hormones that you put out is cortisol and adrenaline.
Yep.
And moms have been known from that burst of those hormones to be able to lift cars off of trapped children. That's how empowering they can be. And yet they're not the only things recruited. Other powerful hormones are recruited. So for a woman, estrogen's a lovely, empowering hormone, and so is testosterone. And
Mm-hmm.
in times of dysfunctional response to the stress, fight or flight biology, a woman's going to recruit her estrogen and her testosterone. And you see this in today's world. Women athletes, a lot of them who train so rigorously are not menstruating. They're recruiting their estrogen not to go down the female pathways, but to go down the empowering pathways,
Mm-hmm.
and they're not menstruating. And so the hormonal balance and how life calls upon us, but here's what it translates to, like you were saying very clearly, Maraya, that midlife, there's been a lot of mileage. There's been a lot of wear and tear. And
Mm-hmm.
it's very common to see almost everybody lower in hormone levels than they were when we were in our 20s.
Yep.
Now I want to bring menopause into this. You mentioned cycling, and how should we approach the replenishing of those hormones? And it's much easier than I ever thought it was. I was very interested in copying nature. A dear colleague of mine suggested that we do that and we not try and invent a new human being. And I had been used to, for example, in a woman in menopause or perimenopause, because her estrogen output varied so much, and I was giving steady doses every day, and I love spreadsheets, and I won half of the Berkeley High School Math Cup. So I love playing with this stuff. So I would take that total amount of estrogen that a woman had figured out she needed over the course of her month in steady daily dosages.
Mm-hmm.
And I would redistribute it mathematically and produce the highest amount on day 12, and it would change 4 times during the month. And I've had the privilege of having a demographic of women that are highly motivated, highly health motivated, very intelligent, very interested. And so I had a lot of compliance, and I would produce these monthly spreadsheets for women. And I did this for a couple of years, and we have an annual visit. And here's what would happen. I would say at the annual visit, well, how's that going? And what do you think of those spreadsheets? And they would say, well, I'm not doing it anymore. I thought it was a great idea, but I felt much better when I was getting the steady doses. And 100% of the women, and I had put so many women on these variable dosages, 100% of them had on their own, because they're in control of their own health. They chose to drop my sophisticated variations there. So what I learned was from the women is those things are very relevant for young cycling women. That cycle is so exquisite. The orchestration of it is phenomenal. You want to believe in the divine, study the female menstrual cycle.
Mm-hmm.
However, midlife's a different thing. And practically speaking, like, for example, is this okay that I'm going on like this, Maraya?
Yeah, it's fascinating.
Young women, the amount of estrogen that they need to be fertile, to regularly menstruate, let's say, is this amount. Well, other young women need 3 times that amount. There's tremendous individual variation there.
Mm-hmm.
How much do you need for menopause? It turns out right below the lowest amount.
Okay.
Steady dosages are what the women are preferring, and it makes sense. We're
Yeah.
not trying to be fertile. We're not trying to menstruate once a month. That's useful for a certain time of life. But the things that are critical to support and nurture and preserve and have every day that you're on the planet Earth starts with vaginal health, bone health, mental health, cognitive. You need estrogen. Oh boy, do you need it. A
Okay.
libido, for skin, for hair. It goes,
Yes.
the list is long, but you
Mm-hmm.
don't need youthful levels. In fact, we want to avoid youthful levels, because no matter what amount a young woman needs, once a month, she prepares for possible pregnancy. And she not only creates and proliferates a uterine lining to receive she also proliferates breast glandular tissue in possible preparation for breastfeeding right there every single cycle.
Right.
There's new cells there.
Yep.
There's cellular mitosis taking place once a month. It's astounding what takes place.
Mm-hmm.
And many women feel this. They feel as their cycle progresses, they're getting fuller breasts.
Breast
And then if
tenderness.
breast
Mm-hmm.
tenderness,
Yep.
that's a different thing, the tenderness. But if they don't have an implantation, everything reverses and the breasts get less full, have
Yep.
their period. And this is going on once a month. Well, it turns out that we don't want that proliferation in a midlife woman.
Mm-hmm.
The optimal amount of estrogen that will preserve bones, will preserve vagina, and so many other functions is right below the amount that it takes to proliferate. So
Uh-huh.
a menopausal woman's levels are different.
Right.
There are
Because we
definitely
don't need the LH and FSH surge.
at all.
Yeah. Okay, so I love that we're really starting to get into the nitty gritty of bioidentical hormones. So for the woman or man who is listening, and they can relate to conversation around feeling fatigue, the reduction in muscle mass, even if they feel like they're working out the same amount and doing weight bearing exercise. They're not sleeping well. Maybe a woman is experiencing hot flashes, sleep disturbances, a reduction in libido in either a man or a woman. You mentioned cognition, brain fog. I mean, there's so many things that can be showing up. Sometimes with women, it's new irritability, new bits of anxiety. And let's say that person goes to their primary care provider, gives this laundry list of the things that they're experiencing. The primary care provider orders blood tests and comes back, and they're told, everything looks normal. It's just part of aging. I'm
I know what
curious.
you think of that.
But what do you think of that?
I'm going to channel.
Yeah.
You
Well,
to,
how do you respond to that? How do you encourage people in the world to be in the place of self-advocacy? What questions do they ask?
this is a big question.
Where do they go to ask the
It's a big
questions?
question.
It's a big question.
And here's what's clouded up the whole question here. For 1,000 years, for those who had access, women and men had hormones replenished midlife. 1,000 years. In the mid 40s, the pharmaceutical industry learned how to mass produce these hormones. 40% of the women in menopause in the United States in 2002 were on hormones. They knew about it. They knew the benefits. And so many women could just go to their primary care provider or their gynecologist and say, I'm having these symptoms. And they would say, sure, take this. You're going to need it.
HRT. Yes.
Yes, take HRT. And those women were doing so much better than women who weren't on HRT.
Mm-hmm.
And then along comes this crisis where a medical study was done in 2002 and it had a false report.
Mm.
The study itself showed a decreased risk for women on hormones, pregnant mare urine estrogen, derived from pregnant horses. It showed that they had a reduced risk for breast cancer. But it showed a statistically insignificant increased risk when the Premarin was combined with a progestin called Provera. Statistically insignificant. What every scientist and every medical doctor knows is that means don't pay any attention to the results. We can't draw any conclusions. But the press grabbed hold of it, exploded it out on the world population, and all that people heard, women, healthcare providers around the world, was if you take hormones, you're at risk for breast cancer. That was not in this.
Wasn't it also stroke?
Yeah, stroke and heart attack. That was a little cloudier, but
Mm-hmm.
that was also in there.
Mm-hmm.
And I read that study. I was alarmed. I had been treating women for 10 years by then. And I went, wait a minute, it says statistically insignificant. And here's a reduced risk for breast cancer. And then I was very familiar with a wide amount of medical literature, including the European literature. And I marched on. But 99% of the providers, medical doctors, nurse practitioners on the planet freaked out. And so here's the complexity to this story. I grew up in medicine. There was a lot of generalists. And then this trend started happening, specialization, where urologists started emerging and neurologists and internal medicine doctors. Nobody could get their arms around the whole field of medicine anymore. And it was to great advantage. When you specialize in gynecology, you get good at one thing. When you specialize in obstetrics, you get great at it. In fact, it's your only chance of getting great at it. If you're doing this wide practice of general practice and you're delivering babies, you never get great. And that has a consequence. Well, the whole world hormones, that wasn't happening. So you've got all these board specializations, not in hormones, not in menopause. So almost anywhere you go, still to this day, you go to your primary care provider. They've had no education in hormones
Or nutrition.
or nutrition. They're frightened of them because
Yep.
the word is not out. And you go to gynecologists who are primarily surgeons, most of them, not all of them. Some of them have a great interest in hormones, but they're rare. They've been poisoned by the same study. And I would like to take the time, if you'll give it to me, to clarify the issue of risk. What is the actual science behind risk? Because most everyone that we ever talk to, healthcare provider or a woman or a man, has got the opposite information. So here's the science. Is it okay, Maraya?
Go.
Here's the science. We're all at risk for thousands of diagnoses. And a lot of them are not okay. We're at risk for hundreds of cancers. As a male, I have a special increased relative risk for prostate cancer. There's reasons for that. These are modern day reasons. These were not always the case. Women have an increased risk for breast cancer, relatively speaking. This is a modern issue. This was not always the case. It wasn't the case when I was in medical school. Given that we're all at risk for a multitude of not good things, here's the science. Women who are treated with hormones are less risk for breast cancer, heart attack, and stroke than women who are not treated with hormones.
I'm curious. Thank you for sharing. And is there a difference between those women who are treated with hormone replacement therapy that's synthetic versus bioidentical hormone replacement therapy from a compounding pharmacy that's derived from plant sources?
We don't know the difference. The science hasn't been done. This is a field that is way behind in actually being able to confirm or deny that statement. Now, here it is, 1992. I'm getting inspired in my practice to do hormones. I'm looking at various things. Let's see. Horse urine derived estrogens, bioidentical, same molecule has come out of the ovary. I wonder, plant derived. I wonder what I want to choose.
Yep.
Well, I've been an organic guy for the last 50 years.
Yeah.
It was obvious to me. And it allowed me an ability to individualize that I had never really had in any other branch of medicine. Because there's these compounding pharmacists that you mentioned, 7,500 of them in different pharmacies in the United States, I can write a prescription for the specific woman and deal with that tremendous individual variation that we're talking about. So I immediately got into that. It just made sense to me.
Yeah.
Just like,
Okay.
are you going to?
Yeah. So let's dig into that a little bit. For the woman who is looking to start or considering to start bioidenticals, let's say she lives in Minnesota versus Orlando versus Los Angeles, and she's going, when do I start? Do I want to stay on the lowest dose possible for the shortest amount of time? Where do I get my prescription? There's amazing experts like you, but your licensure and your prescriptive authority is state specific. Same with me. So where does a woman begin? And this is something I have been, because for me, my clients are all over the world. And I am on a quest to find a consistent and reliable source for a woman to get personalized dosing of bioidentical hormones specifically for her scenario. And so where do we go?
You're naming the number one challenge of most women. It's like they start experiencing stuff, they suspect menopause. What do you do? Here's your job. Go shopping. Identify, do the legwork necessary To identify a licensed healthcare provider, must be licensed to prescribe testosterone, for example. That's a controlled substance that's in your state.
Yeah.
That's all you have to do these days. Telemedicine, the wonderful thing about menopause medicine is it does not require an in-person visit.
True.
All of it can be done through telemedicine. You still have to have a primary care provider as part of the contract with the menopause specialist. So you go shopping and find this person in your state.
Mm-hmm.
And who do you want? Someone who has really taken on gathering the information necessary. So they've studied this field. They've gone to seminars. You can't get it in medical school. You can't get it in residency, but you can get it in various trainings.
Mm-hmm.
So someone who's been interested in the advanced education, best case scenario, you're getting someone who's decided to specialize in it. That's what they're doing day in and day out. These are your very best. So I'll give you some resources here. I mean, number one, download our book. Go to our website, bright.live. I spend the majority of my professional life training and mentoring physicians and nurse practitioners, PAs, and prescribing clinical compounding pharmacists.
Mm-hmm.
And we've done a lot. We've trained over 600, and it's rapidly growing. That's what I
Awesome.
do most of my day.
Awesome. Awesome.
And so you can write us, and if we have someone in your state, because that's all you need, we'll give you the referral name there.
Mm-hmm.
And here's another thing that you want to do is you want to have a preliminary call with whoever you identify. You want to feel good about them. You want to feel like they're going to listen to you. You're going to want to hear their interest in hormones and in individualizing hormones. In best case scenario, you want to hear that they're bioidentical hormone providers, because those who've gone to bioidenticals, they get what happened. That you can do good work with Premarin and Prempro, but it's impossible to individualize. It's oral estrogens. It's a progestin. If the only tool I had was Premarin and Prempro, believe me, I would be delivering it. But
Yeah.
no, this field has come a long, long way. You want the same molecule that's in your body, and you want it individualized, and you can only do that through a compounding pharmacist
I love it.
writing a
I love it.
prescription.
Yep.
There's
And for
something
those of
else
you,
to it.
I just want to really quick, for those of you that are listening, just to make sure you heard, Premarin and Prempro, we're talking about urine from pregnant horses and progestin, not progesterone. And if you're listening on the podcast, if you go way back to the interview I did with Dr. Sarah Hill, who wrote Your Brain on the Pill, what she's talking about is progestin, very different than progesterone. And one other thing to add, in this search for your specific state, you can also simply just find a compounding pharmacy. Find a compounding pharmacy in your state and call them, ask the pharmacist who prescribes the most here in this shopping around. So it sounds like Dr. Rosensweet has some great resources with clinicians that he and his organization have trained. You can reach out there. Also, find a compounding pharmacy in your area. Ask the pharmacist. Okay, sorry, I didn't mean to interrupt.
You went exactly where I think is the second most wonderful tool. And I want to take it one step further. There's going to be a compounding pharmacist in your area or within a 60-mile radius. The best thing to do is actually show up in person. These are very busy folks. They may not talk to you on the phone, or they can't see you. They may not, but when they see a living human being, there's a lot of caring people in the pharmacy world.
Yeah.
And you say to them just what you just said. You know, you're receiving the prescriptions from all kinds of providers here. Who would you recommend for your family?
Yeah.
And so often they're so generous, they'll be happy to tell you, because they knew who's sending in prescriptions that show and reveal a great deal of savvy and those who don't. So that's another great resource. And there's another great resource. If you look around with your friends or their acquaintances and just start asking, you're going to run into a woman who's on hormones.
Yeah.
And there's nothing better than a personal recommendation And if you go shopping, that's what I mean. You keep asking around, then go through the network of your friends.
Yeah.
Someone has been doing it.
Yeah.
Especially go for the older women who look good, because
Yeah.
there's a big difference in a woman, just how her appearance.
Yeah.
If she's older and she looks good, that woman is on hormones. Ask
Hmm.
her who's her resource.
Right, because it's going to impact fine line and wrinkles. It's going to impact collagen levels. It's going to impact vitality and probably even blood flow down to the capillaries. Okay, so for an individual, man or woman, but we're mainly talking about women here who are shopping around trying to find the best provider. Some of the things that I heard is it's someone who is familiar with bioidenticals. It's someone who's open to giving kind of lower doses consistent throughout the month. Yes.
I want to know
Okay.
that is what you hear on the streets,
Hmm.
but it's not accurate. I'm sorry I don't mean to challenge you
I
there,
miss
but
no, I thought that's what I'd heard you say. So I must have
no.
misunderstood what I
Oh,
heard you
okay.
say.
Sorry. Yeah.
Yeah.
That was a myth that someone made up. There's no science to it whatsoever. When everyone got frightened about hormones, there was 18 million American women on hormones. It went down to about 2 million overnight. And a lot of those women got miserable. And they just flooded their doctors and they said, you got to help me. I don't care what the risks are. I can't sleep. My
Hmm.
mood is gone. I'm losing my intimacy, everything. So someone came up with this thought, we'll take the lowest dose for the shortest period of time.
Hmm.
It was not, there's no science to it whatsoever. And
But
I'm so,
wait. Didn't I hear you say earlier to keep the estrogen level lower than the lower point in a normal menstruating cycle so that we don't necessarily have the LH and FSH surge? Did I misunderstand that?
well, it
And
wasn't so much for,
we're talking scientific. For those of you that aren't clinicians, stick with us. I don't mean to go over your head, but I really want to make sure I'm clear on what you're saying.
well, it's what is the optimal level?
Okay. Mm-hmm.
And it's individual to individual.
Yep.
And it turns out that most women don't need those robust levels, wide range,
Yep.
that you needed when you were young, but you do need a certain amount, and it just happens to fall right below what it took to menstruate.
Okay.
And you don't want to go too low, because if you go lower than that, you lose protection of the bones in the vagina. And we back this up. It's in my book. I describe it. You want, bottom line, protection of the bones in the vagina. And if you're having pain on intercourse or you're needing lube, you do not have enough estrogen to protect
Hmm.
your vagina or your bones.
Right.
Some women, there are exceptions. Some women who are having cognitive issues, and that's such a common thing.
Hmm.
Most of them are going to be alleviated by that zone down there. And that's not, I wouldn't call it low. I'd call it low for a young woman. You're
Hmm.
not going to get a period out of this, but it's enough to protect the vagina and bones, bottom line.
And of
Now,
course,
no,
we want to take away the symptoms of hot flashes and sleep
well,
disturbances
yeah.
and all. Yeah.
Well, that's easy. And why I paused us around the smallest dose possible for the shortest period of time
Hmm.
is it's very easy to alleviate symptoms of
Mm.
hot flashes, night sweats, waking up in the night. So I once did a study of 54 women that I had seen in the previous year that I had 24-hour urine hormone tests on. And the time we test women is only when they say, hey, I feel good. My symptoms are gone. That's the time you want to test a woman. And what I learned was 50% of the women who said their symptoms were gone did not have enough estrogen to protect their bones in their vagina.
Fascinating. So
50%.
it's
So
not
when
just
you
symptom
hear
relief.
symptom alleviation is all you need, that's wrong.
Hmm. Hmm.
And that's why I balked a little bit about the lowest dose, because the lowest dose is one of the most common prevalent things out there, but it's
Hmm.
injuring women. It's not what they need.
Right,
And
because we're not just talking symptom alleviation, we're also talking protection of bones and cognition and longevity, which it's kind of like we floss and brush our teeth. and we don't feel ourselves preventing cavities, but kind of approaching it in a similar way. So when do you suggest that women, I'm obviously this is broad, everything's personalized, but in broad strokes, when would a woman start considering bioidenticals, at what age, and for how long? I've got a client right now who's 65. She's not having any symptoms. She actually wants to go off of her bioidentical hormones. She doesn't feel like they've made any difference with symptom relief. So I'm curious if you have thoughts on kind of generally, when does a woman start and when will it end?
Let me go to the end first.
Okay.
Well, just to give you an example, my last day of going to be on a robust dose of testosterone is going to be when I can't open the bottle anymore. Or someone
for those of you listening on the podcast, he was showing his bottle
of testosterone.
Okay.
And I suggest the exact same thing for women. And of course, all you have to do is talk to a woman who's been on hormones and been successful. She's not going to want to let go of that bottle until the day she can't hold it anymore. Now, the women that I'm most concerned about is one of the clients you just described. 85% of women in menopause have symptoms: strong, stronger, strongest, life-stopping. They get inspired. They're not asking the question, do I need hormones? They're going, my life is so disrupted right now. You got to help me out here. 15% of the American women don't. They don't have symptoms. They're undergoing the same loss of bones, the same loss of muscles. Walk the beaches of Florida. See how many old people you see walking. Not a lot for as many that are down there. Take a look at their lower extremities. Thin lower extremities, sarcopenia. So 15% of women, they're looking around going, what is everybody complaining about menopause? I had the easiest menopause possible, no symptoms. They're the ones that are at most risk because they're going to sustain the same losses. But when are they going to wake up to them? In their 80s, when they're transitioning to a walker because of sarcopenia, or to a wheelchair? So yes, your friend, I would say to her, double down. Make sure your doses are adequate here because you don't have the same signals. So that's at the far end. Never stop. I mean, there's no reason to. Your risk for trouble is less in so many ways. When do you start? Well, there's a lot of clues in a young woman. Sometimes you don't have any clues until your 40s. But sometimes you start getting clues in your 30s. Your periods start getting irregular. Ooh, if your periods are getting irregular, you have all but lost the most prevalent ovarian hormone, progesterone. In order to produce progesterone, you need to ovulate. If you don't ovulate, you don't produce 100 times more progesterone than you do estradiol.
Right. And I want to make sure everyone hears that. If you didn't have your period, if you didn't bleed, it means you didn't ovulate. Ovulation is considered the main event. If you're not ovulating, it means your body's not producing progesterone. Yeah? Okay.
And it's even more than that. It's if your periods were clockwork regular, in order to have clockwork regular periods, you're ovulating. You can pretty much bet on it, and you're fertile. If you got clockwork regular periods, if you had clockwork regular periods and you're no longer clockwork, you are no longer ovulating. Your need for progesterone is huge. And this can be in the 30s, but it can be more subtle than that. Like I said, let's pretend that this is progesterone and this is estrogen, of two of the four ovarian hormones. You're 20 years old, they both decline. But what's a well-known thing is very often the progesterone declines earlier and deeper than the estrogen. This is very consequential. So if you're a young woman and you're in your 30s and all of a sudden you're getting anxiety and you look at your life and you go, I got stresses, but anxiety? Or I'm not sleeping as well, or my mood isn't the same. You're having that imbalance where the progesterone's dropped lower. You can benefit by progesterone. And progesterone is often the very first thing needed.
Do you usually give oral progesterone?
No, I always start with topical.
Okay.
But we give out a lot of oral.
Hmm.
That's a whole subject.
Yeah, I know. I'm aware of time. I feel like we could keep. Of course, I want to pick your brain around. Well, what about nutritional things that women can do and supplemental outside of bioidenticals and nuancing it. But I'm aware that you have another call and
Oh my God.
I know. I imagine that everyone listening, you probably are left with more questions. Thank you for sticking with us this long. Hopefully, it's been thought provoking.
I'd be
Like
happy to
Dr.
come back, Maraya. You're obviously super good at this and super knowledgeable. And so the
Thank you.
depth of questioning here, we're going into the weeds, the important weeds. So if you wanted me to come back, I'd be honored to come back.
Yeah, we can definitely do a second one here. And for those listening, if you have specific questions when I have Dr. Rosensweet back and you would like those questions asked, please ask them. If you're listening in the podcast, wherever it is, or you're on the Facebook Live, ask those questions and let's reschedule another time because it does feel like there's more here and it's a really important topic. Um, any last parting words for those that are listening? And obviously, I want to thank you for your time and what you're doing for the advocacy of both men and women, and training clinicians to be able to, be able to approach this with the training because like you said, it's not something that we learn in school. Even with CME hours, it's not an easy thing to find. So thank you. And any last parting words?
Go for the organic oils as a delivery system.
Mm-hmm.
The safest way to take testosterone and estrogen is by the skin. And the safest is a certified organic oils delivery system. So you're not putting solvents on your skin.
Uh-huh.
I
So
just
then we're
snuck
getting
that
into the
in.
endocrine disruptor conversation. Is that where you're going
Yes.
there?
Yes.
Okay.
Other place. So I snuck that in.
Yeah. And my understanding is you have your own line. Is that true?
We do. We
Yeah.
supply this all around the country and
Hmm.
now Canada, and it looks like we're hearing from Europe. So we'll see. It's going to be available.
Okay. So to be continued for now, for those listening, you can download his free book, the PDF, and just follow him on Facebook, Instagram, start exploring, ask your questions. Sounds like maybe I need to become a trained clinician. Thank you. It's been thought provoking and sounds like there's more to come.
Honor to meet you.
Yeah, you too. All right.
Bye
Enjoy.
bye.
Bye. And once again, to everybody listening, I really do appreciate your time and your dedication. Because if you've listened this far, it tells me that you're taking your health seriously and you're investing in your well being, right? Proactively. And I know that the one thing that is most scarce, in my opinion, is our time. We don't get it back. So I honor the fact that we've just had this exchange of time, energy, frequency, and vibration. Hopefully, you've gleaned a great deal from this conversation. And like I said before, ask your questions, comment down below. You're welcome to reach out to me. I'm super approachable. Maraya Brown in all the places, marayabrown.com, Maraya Brown on Facebook, underscore Maraya Brown underscore in Instagram, Maraya Brown in LinkedIn, if you get the picture. And would love to hear from you. And we will, sounds like, continue this conversation. Until then, cheers to your wellness, cheers to your health, and cheers to your hormonal vitality. Ciao, ciao.